So good morning, everyone, and welcome to our second day of our Assistive Technology and Community Living Conference. I had said in the opening session that I attended the keynote and 5 of the sessions yesterday. It just blew me away. The presentations were just so extraordinary, and I'm sure today will be as excellent as yesterday. I'm going to keep my comments really short because we're thrilled to have Assistant Commissioner Jennifer Jacobs here today, our Medicaid Director. She is just such a friend to Disability Rights New Jersey and individuals with disability and disabilities in New Jersey. And we're just so honored that she agreed to speak today. So thank you, Assistant Commissioner. Jen has an amazing background. She taught 5th grade, I love that, in Jersey City at the start of her career. She spent some time in the New Jersey Senate Majority Office and focused then on issues of healthcare access at AmeriGroup. She spent some time in Florida. We have to kind of wonder about that a little bit, her flip-flop era of her career. And then soon before COVID started, returned to New Jersey as our Medicaid Director. I'm sure, she didn't have a crystal ball and didn't know what she was coming back to. But I think that with her leadership, in the Medicaid agency, the response has just been amazing to the pandemic and all the work that she and her staff have done to ensure that people have access to Medicaid, that their needs are being met during this time, and really thinking in an innovative way how we can take the lessons learned from COVID and move our Medicaid system forward, and especially around ensuring high quality home community-based services on the other side of this. And she's going to talk about a lot of that today. And I'll just finish up by saying she graduated summa cum laude from the Honors College at Penn State, and she has a master's in urban planning and policy from MIT. So welcome, Assistant Commissioner. We're thrilled to have you here today. And I'm going to turn it over to you now.
Thanks so much, Gwen. And you are a true friend to our program. We so greatly appreciate you as we're thinking through how to handle some of the challenges that we run into. You're always one of the first people we call. And I'm thrilled to see a whole lot of names here that I don't recognize. You and I have both been working in New Jersey Medicaid world for a very long time. And usually I know almost everybody in the room, but here it seems like I'm getting to talk to a whole world of folks I haven't had the opportunity to talk to before. So hello to everybody out there who I know already, and a big hello to those of you I haven't met yet. I'm really excited to be here with you today, and I'm going to share my screen now. Just to give you a sense, I'm a visual learner. I understand there's some educators in this group, and if you're a visual learner too, these slides are for you. If you can't stand slides, feel free to minimize them. I'm just going to sort of talk through, and the slides are really more of a reference for both of us on what those topics are, and I'll make sure that I make this available to Gwen and the team later, so that you can use it as a resource if you would like that. So thanks, Gwen, also for mentioning my background. I come from community work. I started my career as a teacher. My once 5th graders are now in their 30s, which I don't like to think about, but they are the people who anchored me in my desire to serve our communities and make the system work better for people. I would love for the system to be magically overhauled and completely different. My intention is to be part of change and positive direction for the system that we have. How do we just make it better and better? And so I wanted to talk to you today about what's been happening here over the past year or two. And I know that it's in some ways the same stuff that's been happening in everybody's workplaces. And really what comes to mind for me, and maybe is relevant for you, is there was a great social reformer around the turn of the 20th century. Her name was Jane Addams with 2 Ds. And she was doing, social work with women and with immigrants in Chicago, and really doing it differently than Mostly men were doing it at the time, or not at all back then, and somewhat controversially. And I think if we look back on Jane Addams and the work that she did, it might be controversial to us today too, because the thinking in our society has evolved over time. But what I took from her was a lesson that that one of those sort of well-established men who was watching what she was doing said about her. He said that the reason that Jane Addams was so effective at making the system work better for people, giving people resources, helping to improve outcomes, was because she brought velocity and stability to the work she was doing. I read that line in a Jane Addams biography in 2003, and it has stuck with me virtually every day of my career since then, because I realized, yes, like when we are trying to do something really challenging, something unpredictable, something where there's not broad agreement, where people are frustrated by a system or not necessarily, all on the same page, as leaders, and I think many of you out there think of yourselves as leaders in your organizations and in your communities. As leaders, we have to think about those two things. Velocity is giving everybody an opportunity to move forward together, right? We know our pace, we know our direction. This is how we're going to do it. Here's where we're going, right? Setting that vision out. And stability is giving everybody a sense that we will get there together in one piece, right? We will work through the crises, we will troubleshoot and get there together in one piece. And so that phrase just always sticks with me, and certainly with respect to what's been going on in the world the last couple of years. And then for where we're headed, there's a couple big things I want to talk to you about. As Gwen mentioned, new investment in home and community-based services, really important to independence for people with disabilities and older adults. And then the renewal of our 1115 comprehensive demonstration, which includes a dialogue about integration of medical and behavioral healthcare coverage. I want to talk to you a little bit about that. And all of this is grounded in a focus on health equity and doing our part for social justice. I'm really excited to be serving the New Jersey Medicaid community during a time when America is reckoning with this differently than we have in the past. I'm proud to work in Medicaid for all of these years, including my accidental move to Florida, which was fun for flip-flops and palm trees, but I am a Jersey girl. And all this time, all these years that I've been working on Medicaid, health equity has been a focus, social justice has been a driver. But America is looking at this differently than we ever have before. And I think that's important. At the bottom line, we're focused on serving the whole person. And you'll hear that theme, I think, throughout this discussion, the best way possible. And so let's dive in here. For some of you out there, policy wonkery is a fun career or hobby. And the work that we do sits within this very broad policy context. So I always want to kind of put the tools of policy out there for folks. And I think this diagram is helpful for the policy inclined to understand. We have multiple tools. These are really just the big ones. Multiple tools that we use to advance our policy objectives in the Medicaid space. And the couple I'm going to focus on today are highlighted in yellow for you. We're going to talk about that 1115 comprehensive demonstration renewal. And then we're going to talk about the HCBS, Home and Community-Based Services spend plan, give you a little bit of context and what's going on with each of those things, but they exist in the context of that broader set of policy tools. So neither of those things is doing everything. And so I'm going to sort of think of our broad set of policy and the big picture for NJ Family Care in blue in a couple of these slides to come, and those highlighted tools in yellow. So you'll see that come up again. For those of you who do not identify as policy wonks, we can also really just think of this as the services we provide to 2 million New Jerseyans and our ability as a program to be responsive to the needs that our community is describing to us. So if you are not into, policy levers, you don't need to be to understand what we're going to talk about today. You can really just think about it as the people we serve and the services we're offering them. So talking about what's been going on, of course, it's hard to talk about our work in the past couple of years, as Gwen indicated, without talking about the public health emergency. And when we were putting these slides together for you to kind of guide this conversation, we put together a slide for 2020 to give you a sense of how we responded initially to the beginning of the pandemic, March 4th of 2020, which was a birthday I will remember for a long time. And then we put together also a slide for you on 2021, right? And I was like, oh my God, it's 2 years. It really is the bulk of 2 years, goodness. We have come through it together. We've had some really hard times inside our own organizations, certainly I know in yours and in our communities. And this was personally and professionally challenging for all of us. What I would say from a Medicaid program point of view is we needed very quickly to focus on what we've identified in these 3 blue boxes. Number one, we needed to protect and extend people's access to Medicaid coverage. So what did that mean? It meant that we had to keep our eligibility operation running, even as our counties and our vendors were getting hit by the pandemic themselves. We needed to continue processing Medicaid eligibility so that people would have the healthcare coverage they needed during a global pandemic. That was non-optional. And also at the same time, we needed to grind our systems to a halt on disenrollment, because we would not disenroll anybody during the pandemic. The federal government included provisions for that, and obviously that would be a priority for New Jersey. So we needed to make sure that people who were trying to get on Medicaid could get on Medicaid, and everybody who was already on would stay. That was an enormous lift for our technical teams and for the counties that we partner with. We really, we had a big challenge there in the beginning, and we have managed to keep that, as I said, velocity and stability, keep it stable. Then we also had to focus at the same time on making sure our members got the care they needed during especially those early days of the pandemic, when the shutdowns were happening, when there were grave concerns about people not being able to get access to healthcare. And that meant working with our managed care organizations and then creatively with our providers to solve problems that we were seeing out there. We immediately got together with our managed care organizations. We said, we're going to have to be strategic and thoughtful about this. We're going to have to make the best decisions we can with the information we have at any given moment. And as you know, that information was changing all the time. So the other text on this page, the bullets at the bottom, just represents some examples for you as we asked our managed care organizations to begin reaching out to particular populations who we believed in March of 2020 would be at high risk for COVID-19. And as you know, that was an evolving concept by itself, just understanding what risk looked like. But we said to them, we need you to start outreaching your highest risk members right away to understand what's going on out there. What is the experience they're having? For example, are home health aides getting to people's houses? Are people having trouble with transportation to critical appointments like dialysis? And we set up a weekly meeting with them. We talked every single Thursday at 8:30 a.m. We still have that weekly meeting because we knew the only way to respond to our community was to know what was going on the ground. So we were meeting with managed care every Thursday, meeting with the counties every Wednesday, meeting with our community members, and really trying to make sure we were putting all that information together. And then, 2021, the focus shifts to vaccination. And I know that the font is a little, depending on the size of your screen, the font is a little small on this page, but the red, orange, and yellow triangle is really where it's at. We worked with our medical directors and we said, look, a big chunk of our population is eligible for the vaccine very early on. How are we going to focus our outreach? And we recognized that there were certain members of our population who were still at higher risk for COVID, and that was the group we really needed to focus on. So managed care started making phone calls to our RED group first, and RED was age 75 plus with 2 or more of the priority conditions that Department of Health had and CDC had put out there. And then after initial focus on RED, we also focused on orange. So continuing to work with our RED group, but then also beginning outreach to the orange group, which was 65 plus with priority or moderate conditions. And then the yellow was our much broader group. They didn't become eligible for the vaccine until a little bit later. And then of course, our 12-year-olds and up after that. So we've had to kind of evolve our strategy as we go. And our intention there really was to work with managed care, and in particular, their data wizards to be able to know our progress in the communities. So we partnered with Department of Health on the immunization registry. Managed care had some claims and member reported vaccine status. And so we were able to begin collecting data from them to understand what was going on with vaccination. They also, managed care folks were very helpful to us in partnering with community organizations. So for example, when there was a FEMA vaccination pop-up site in Newark that would be open for several weeks, we got together with our partners at Department of Health. Managed care organizations were reaching out to members in that area, letting them know, helping to arrange transportation. And then if they said they didn't want to go to the Newark site, but they wanted to go somewhere else, Department of Health was able to help us get them an appointment. So a lot of partnership across different organizations has been very critical. I could talk about this all day, as you imagine, because it's a big deal for all of us right now. But I want to make sure that we also have lots of time for other critical topics. So I'll jump forward a little bit, but if you would like me to come back to that at any point, just let me know. I also wanted to chat with you about some of the progress we've seen, because we're going to talk about the 1115 comprehensive demonstration waiver renewal a little bit. We have seen progress from the 1115. We still see lots of opportunity here, but we've seen rebalancing of our long-term care system. I think notably in the first 5 years of our MLTSS program, which happens through the 1115, we saw New Jersey's elderly population grow by more than 12%, but the nursing facility census declined by almost 5%. So that was 2014 to 2019. And what that says to me is that we are doing better at helping people remain in the community. And it's just one indicator, and there are lots of others that give us a sense of direction. And I think it's a good indicator that, you know, resources are out there. We're starting to move in the right direction. We also have to work with some of the real life challenges on the ground. And we have, through that waiver, we've improved access for adults with intellectual and developmental disabilities. I think many of you are familiar with the supports program and the community care program, and we have been able to grow participation in those programs. As a result of this work and some of the other work we've done, for example, around self-direction, we received a Pacesetter Prize from the SCAN Foundation. This is based on our progress in AARP's LTSS. Oh, that was too many letters. You all know AARP. They do a report card on long-term services and supports, and they rank the states. And the SCAN Foundation saw our progress in the rankings and recognized us as a pace setter. So that was an exciting moment in the middle of a global pandemic. It was nice to receive that recognition. I also wanted to give you a couple of updates. These are things where if you're paying attention to Medicaid every day, this stuff is really important and I think really exciting. If you're not, it may feel a little bit, I don't know, administrative. But to me, these two things matter. One, we're doing a lot of work around managed care accountability. I spent 15 years in managed care. I am passionate on this subject. I think they can be really great partners to us. They have certainly been phenomenal partners during this pandemic and in lots of other ways. We need to make sure that at all times we are ensuring access to high quality care through our MCOs. So we're taking steps within our contract to make it tighter and smarter around managed care accountability. For one thing, we looked at network submissions, provider network data, and we said, you know, it's not as important to us that a managed care organization has signed a contract with a provider as it is that that provider is available and serving their members. And so we tied network adequacy review to claims submission. Not that the provider is contracted, but that we have claims indicating they're seeing members. That feels like a way to get at what I call the true, what's really going on out there, who's really serving our members. And we also put some, you know, there's carrots and sticks. We put some sticks in place around MLTSS caseload non-compliance. And so that's something that we've been tracking. Very importantly, we have set up a 360 review that happens every month. We're looking at the MCOs on a deep dive and following up with them on issues that they may or may not be aware of. Sometimes when you're running an organization, I can say this as a Medicaid director, when there's 50 other Medicaid directors out there, you don't know how you stand up compared to another. And so we have 5 plans. They don't always know how they compare to the other plans. And we're making that clear to them. Here are your strengths. Here are your weaknesses. This is the stuff we're worried about. And so that's been a really good process, sheds a lot of light on the circumstances. And for eligibility processing, and for my legal colleagues here, I know that this has been an issue in the past, and I hope we will soon be able to consider it history. We've moved all 21 counties onto a common memorandum of understanding where they have agreed to terms of performance accountability for eligibility processing. Lots of detail behind that most of you don't care about, but the important thing to know is we are turning Medicaid applications around faster than we ever have before. Some of that is because of high-tech changes we made in our systems that are streamlining, making processes more efficient. Some of that is low-tech stuff, just really talking, meeting regularly, and going over the data together differently than we had been doing in the past. So, an ABD, aged, blind, and disabled Medicaid application can take a little bit of time to process because it's a little bit detailed. So that one takes longer than the other application. In February of 2019, we were at an average of 67 days to process an application like that. Today, we are at 27 days to process an application like that, same application, apples to apples. So between high tech and low tech changes, we really are seeing results. I'm very optimistic there. Now let's talk about the future. Where are we going, right? Where is this all going? Who wants to think about COVID anymore? We'll move on. So we're going to talk a little bit about supporting independence with a lot of new initiatives. As I said to you, bottom line, all the time, Medicaid has to be focused on health equity and social justice. This is why we're here. This is what we do. If this stuff isn't your passion, like you don't belong in Medicaid, right? Our team is super focused here and we're more strategic now. The nation is more aware. Medicaid directors are talking about how to measure, how do we get at this? How do we know we're moving the needle? And I think, what's really important to recognize is we have these new initiatives that are aiming to promote health equity, reduce the disparities we're aware of with respect to maternal child health, social drivers of health. We're trying to get at it in new and different ways. We are looking to extend postpartum coverage, for example, to 12 months instead of 60 days. We were not able to get an extension approved under the prior presidential administration, but we do think we have an approval coming very shortly from the current administration. And we're doing some exciting work around housing and community health workers. And I'm going to talk to you about all of this over the next few minutes. We also have to make sure we're doing the evaluation work. So, there's day-to-day sort of operational reporting that we're doing right now. For example, when we look at COVID vaccination rates, we're looking at who's getting vaccinated, where, how do we break out by race and ethnicity, by age, to make sure that we're using our data to the greatest extent possible, to make sure that our program is really equitably reaching all of the people who we serve. And when you look at that great big program, 2 million people, $15 billion, if I can't boil something down to one page, I'm in trouble. So, we really want to serve people the best way possible. We want to experiment with new ways to solve problems. And we want to focus on integrity and real outcomes, what I think of as the true, where the true is like a number on a page, and the true is what is really going on out there. So let me talk to you a little bit about what that looks like. Remember, I said I think of the blue as like the big picture. The blue is like our whole Medicaid world. But we're going to dig into those two yellow highlights that I mentioned earlier. One is the Home and Community-Based Services Spend Plan. This was an opportunity from the federal government. You policy wonks already know what I'm talking about, and there's a link at the end of the slides for folks who want to dig in further, but an opportunity to invest new funding in specific home and community-based services that would enhance and support our HCBS ecosystem. And we were really excited about this. It was unexpected, and we had like 5 minutes in the grand scheme of things to meet with our stakeholders and say, how can we use this unexpected funding opportunity? And so where we landed was we will improve access to HCBS by enhancing our no wrong door system so that access to HCBS connections are efficient and clear. So we want to make sure, for example, that when you walk into an ADRC, Aging and Disability Resource Connection, that they are well acquainted with the benefits that are available to you through Medicaid, which I think they largely are already, and that they also have partners in the managed care organizations, partners at Medicaid at the state, partners in the counties, that we are all working together. So no wrong door actually works better for people because we have better connections amongst ourselves. And a really big deal in this proposal, which is still pending approval at CMS, we would like to develop subsidized housing that is dedicated for Medicaid members who are at risk of homelessness or institutionalization. These members typically qualify for other housing as well. But we recognize that there are challenges sometimes in accessing subsidized housing, and we want to make sure that there's a set of homes that are available for Medicaid members. And so we've proposed this in our HCBS spend plan. And then we also recognize we've got to support that HCBS workforce, and in particular, really develop that workforce and increase the rates that we're paying to be able to sustain the workforce so that they want to continue serving the people we serve because they feel they're being paid a reasonable wage. So that is included a number of rate increases. A few of them highlighted here are included in our HCBS spend plan. And then a lot of focus on supporting transitions. So improving our accountability for transition success, improving person-centered care planning, which I'm very passionate about because I know when it's done well, it works like a charm. It recognizes the strengths and preferences and goals of individuals versus checking boxes within a system. And then we also proposed implementing intensive mobile services for youth with IDD and behavioral health needs. So there's a lot of opportunity here in the HCBS program. The other tool I wanted to talk to you about today, and I'm going to have to kind of go lightly through the 1115 because we could spend 20 hours here too, and have. But we'll talk about the 1115 a little bit deeper to be able to describe to you. We want to maintain momentum on some of our existing elements. There's a lot in there that's working, and then we see opportunity to better serve the whole person around social drivers of health and integration of behavioral and physical health care. Seeing those two things as separate is, I think, a little bit old school, and we want to make sure that we're moving into the future. And then serve our communities the best way possible, right? Where we have known gaps and quality issues, we want to make sure that we're improving those, and we've got to bring health equity analysis into a new era. So let's talk a little bit about specific elements of the 1115 that really fall under the expertise of John Seafried, my colleague at the Division of Developmental Disabilities, and his team. They have proposed some changes to the community care program and the supports program. And the intention of those changes is to reduce some churning. This was an administrative detail that was driving a little bit of churning between MLTSS and DDD programs. We're trying to tweak that, get it fixed. A little bit earlier, eligibility for members who finished their educational entitlement. Greater flexibility and support during transition to the waiver programs, and allowing certain services to be provided during an inpatient hospital stay. This is a message that came to us from our Medicaid community. And then enhancing the respite benefit, which is also a message that came from the community. And then our colleagues at the DCF, at the Children's System of Care, also would like to move a couple of details forward here. One around full implementation of an existing authority for children with IDD, and then proposing an income disregard when determining Medicaid eligibility for certain kids. So this would allow children who currently have access only to waiver and behavioral health services to also receive the full state plan benefits. Speaking of independence, really, really excited about sort of dipping our toe into housing a little bit more than we have before. Let me orient you quickly to this diagram, just so that you have a sense of what it means. And then maybe if you want to come back to it at some point, you will. These 4 boxes at the bottom are, these are the folks who are out in New Jersey doing the housing work already, and they are working together. So that's why you see the blue crosshatch behind them. If you tried to put referral arrows between these 4 organizations, it would be all over the place because they work together constantly, right? Housing agencies are working with community organizations who are talking to property managers, and emergency housing assistance obviously is always in the mix. And we recognize that there are places where our members fall through the cracks, and that blue stripe down the middle of the rectangle is meant to give you a sense of what we've heard and how we're responding. So we've heard that members sometimes need assistance, for example, with a housing voucher or getting into new housing. They may need support maintaining their current housing, for example, if they're having an issue with utility bills or paying their landlord, and they may be at imminent risk of homelessness. This is where we feel that our managed care partners can help us, because if you look at the top row of boxes, the care management teams understand what is going on medically with this person. And the MCOs have housing specialists today that we've asked them to leverage to support our MLTSS population. We're looking to expand that in the 1115 so that we have housing specialists available across our population to all of our members who are at risk of homelessness or institutionalization. And then we're going to set up our own housing team, because we recognize, we're talking to managed care every day. We also need to be talking with the other players in the housing ecosystem to make sure that we're not reinventing anybody's wheel, right? We're leveraging the expertise that's out there and the resources that are out there, and really just becoming part of the ecosystem to help make sure that our members are getting the services and support that they need, including housing, which we know is critical to health outcomes. Couple of important things happening in MLTSS around caregiver respite and caregiver support, and some new nutritional services. There are also nutritional services outside of MLTSS. We're proposing a medically indicated meals pilot and a community health workers pilot as well. You can see some of what's going on there in social determinants or social drivers. And I guess I would just say to you here, you know, there's a lot more in the 1115. It's an enormous document. This all came from dialogue with our Medicaid community, what you all have been telling us, troubleshooting from our teams based on what they see happening on the ground, and innovations for supporting independence, things we're learning from thought leaders around the nation, from other state Medicaid programs. You know, we're really just trying to make sure we're putting the very best ideas into our program and evolving to be better and better all the time. There's a few slides in here around behavioral health, and I don't want to go too deep on that because I realize we're a little tight on time. But when we talk about behavioral health, we have a division today in our behavioral health program where managed care pays for some services. I'm going to skip to here. Managed care pays for some services, mostly inpatient. And for a few populations, managed care also covers outpatient services. That matters when someone has an inpatient stay and they're discharging and they need to coordinate outpatient services. But managed care doesn't cover those outpatient services yet for our whole population. So what we're proposing in the 1115 is, look, if we all agree that there are benefits to treating medical and behavioral health as one person, right? Then it probably doesn't make sense for them to be completely separately handled in our system. And we see examples of that every day. So what we would like to have a conversation with our community that goes like this. Phase one, let's review existing managed care carve-ins and decide what are the optimal levels of integration here, right? Where is it working? Where is it not? And then let's offer that optimal integration to all of our NJ Family Care members. That's phase one. It's a conversation. We don't know yet exactly what that's going to look like because that is intended to be a stakeholder discussion. And then phase two, we want to review opportunities to integrate these other services that are not yet touched by managed care, not coordinated by managed care. They're sort of really very separate, but that conversation comes down the line. We're really focused on phase one right now. And so that'll be our initial focus. I skipped over a few things, Gwen, in behavioral health because I realized I'm a little tight on time. I wanted to make sure I got to this slide so that folks have the resources that are available here. And then maybe we have a couple of minutes to do Q&A. I'm happy to go back to any of these topics or anything new that you would like to talk about. And just thanks again for the opportunity to join you here today. You talking to us, Gwen?
Sorry, I was on mute. Yeah. I'm so sorry. And I was actually trying to multitask. That was in the box, but instead I'm going to put the question out to you. So somebody was asking if you could explain managed care versus CMOs, because a managed care organization is not a CMO. And I started typing that answer, but I'll throw it out to you, Jen.
What was your answer going to be, Gwen?
My answer is going to be CMOs are care management organizations that provide services to children with complex needs, and they work with the children's system of care. And I'm sure will be part of what you talked about, you know, some of the changes under the 1115 waiver to the children's system of care, and perhaps also some of the expanded home and community-based services with respect to the mobile crisis teams. And then the managed care organizations are essentially health insurance providers that provide the services to all Medicaid recipients. And I believe we have 5: United, I'm not, and with no preference, Amerigroup, so on and so forth.
Yeah. So the way I think about it, we have our managed care organizations, our Horizon, United, Amerigroup, WellCare, and Aetna. And they have similar responsibilities to the CMOs in the sense that we expect they will provide care management services to members based on needs that we identify and needs that they identify. I think what makes them really different, to Gwen's point, is they're responsible for all of the medical and to the extent that we've carved in behavioral healthcare expenses of these individuals, and they are at risk for those expenses. So it is more like health insurance, as Gwen said, but I think of it as health insurance because it's Medicaid health insurance with a heavy dose of care management and health equity and quality. And it's not in my experience like the health insurance that I have. It's much more high touch and focused on making sure that we're addressing care management needs.
Thanks. We have a couple of other questions in here, which I'm going to throw out to you, but I do know we're a little bit short on time. We have about 3 minutes. So I first want to say just like, a huge thank you. That was an outstanding presentation. It's complicated, but I think you do a really great job of meeting the needs of those of us who are policy wonks. And for some reason, back in 2011, when New Jersey first started going to an 1115 waiver, decided that that was the thing to dedicate a career to. I was one of those people. And as well as, making it real for people who may not have that background. And the other thing I'm just hugely excited about is we have so many people on this from New Jersey, but we also have people from around the country. And I would just say, go back to the people in your state. If you're not the Medicaid policy person in your state, go back to the people who are and say, you got to watch this presentation on disability rights and ATAC's website to see the amazing innovative stuff that's going on in New Jersey and Medicaid. So just a huge thank you on that. It was wonderful. I really, really, really appreciate it. And I also just would echo on this page to be able to put in the comments, and there is a session next week, right? The 27th, I believe, a listening session and comments. I know we at Disability Rights New Jersey are in the process of our comments, and I just think that getting that input from the community is so essential as you move this forward. So encouraging everybody to do that. Okay, so we just have a couple of questions and we have like a minute. So one question is, what gaps are you seeing for people who need assistive technology in New Jersey? And I guess tying that to anything that you're doing through either the spend plan or the waiver itself.
That's a really good question. I would love to hear from folks in the audience, maybe after this, about any gaps they are seeing. The only thing I've heard recently is, potentially some delays in equipment because of some of the supply chain issues that resulted from the pandemic. I heard a couple of issues with folks just not being able to get something timely because of that, which I think is a global issue. But if there are other specific gaps that folks are seeing, Gwen, I would love to, maybe they can direct that to me through you.
So I'm going to suggest for this question, and there are a couple of others, that I'm going to ask Mike if he could send them to me in email. I will send them to you by email. Perfect. And then maybe get a response. I just want to say something on that assistive technology, because it actually was related to a question that I had, which has to do with transition services. So one of the things we're doing here at Disability Rights New Jersey is launching a children and youth team this fall, where we start working with children holistically in their legal needs instead of having a special ed team and a VR team and a children's system of care team, really that the attorneys and advocates who work with those children, youth, and their families have legal expertise across all of these systems, which translates into silos in New Jersey, right? And how those all work together. And I think that's also true in AT, right? Because you can get your AT through Medicaid, you can get your AT through school districts, you can get your AT through VR. So I would just sort of as an ending thought, ask you to just touch for maybe 30 seconds on how we can help break down those silos and really make it so that, you talked about no wrong door, but how people can access these services and supports without just the confusion and sort of bureaucratic challenge of these different silos.
Yeah, I've experienced that from where I sit too. And the thing I have found to be most helpful is bridging the gap with very regular informal connections. We can always set up a formal connection, right? But having that opportunity to troubleshoot specific issues that we recognize as representative of a systemic concern, right? Here is a case of an individual who experienced a certain thing. The system left hand didn't know what the right hand was doing. We have to work through those with specificity, right? But we recognize that one case can be representative of a lot of people's experience. So we just use that case as, and Gwen, you and I have done this, right? And so in the course of doing that, we've met the right people to work with in different silos and set up regular cadences so that we're working together on problem solving. So we have a weekly meeting, bi-weekly meeting with Department of Health. We have a bi-weekly meeting now with the counties. We meet with managed care. We meet with aging advocates, and just keeping that regular touch base is helping us make the connections to solve the problems. But getting those specific challenges, the real data to work with, the individual case, how did this impact a real person, is critical, so that then we can recognize probably more than this one person have had this experience.
So thank you. I think that's a great note to end on. This was, as I said, thank you again. This was just so much really wonderful information. We'll take the stuff in the chat box. Mike, I think, is in the background. He's having some technical difficulties, but he'll make sure that these questions get to me and I get them to you. And people, if you have any other questions, you can send them to us at Disability Rights New Jersey. And I think a conversation that will continue into the future. So thank you very much, Assistant Commissioner.
Thank you, Gwen. Thanks, everybody. Nice to see you.
All right, everybody, I think you have a little break now before the next session, which starts at 10. And thank you so much.